welcome to The Code Tray, the podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EMED-PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
Today, going to be discussing how time is very critical, anticoagulation reversal time after an intracerebral hemorrhage. Myself and my mentors, we have no conflicts of interest to disclose. By the end of our discussion, you will be able to recall the epidemiology and risks of intracerebral hemorrhage, review limited literature surrounding the timing of anticoagulation reversal, and finally, we'll evaluate the article Time to Anticoagulation Reversal and Outcomes After an Intracerebral Hemorrhage. Before jumping into the literature, I wanted to provide a brief background. Intracerebral hemorrhage, which I will be referring to as ICH, is bleeding within the brain parenchyma. It can account for up to 15% of all strokes, and there becomes a growing number of incidents as we see a growing population of patients on anticoagulation therapy, as well as an aging population. Despite all of this, ICH, specifically anticoagulant-associated ICH, doesn't really have specific guidance as far as therapy management, which can lead to high financial burden, disability, and morbidity and mortality for the patient. Hemorrhages within the cerebral parenchyma are often categorized with a primary and secondary injury, which I will discuss on the next slide. The primary injury, however, though, is the immediate tissue injury and can be broken down into several phases. These begin with the initial extravasation of blood into the parenchyma. The next phase is when there is subsequent bleeding that causes expansion. As a result, there's swelling or edema around a hematoma. Although the mechanism of the hematoma growth isn't completely understood, it's hypothesized that there's an upregulation of the inflammatory cascade, which causes an imbalance in hemostatic mechanisms. So as you can imagine, the primary injury is exacerbated when anticoagulation is involved as well. In regards to the pathophysiology of a secondary injury, there's activations of several pathways, as you can see from this image, including pathways in inflammation, iron and blood-related toxicity, as well as oxidative stress. Although the pathways are very distinct, they're mechanistically overlap, and how they cause injury to the brain is very similar and kind of utilize several different routes and pathways, as you can see. For example, if you see edema development can also lead to additional mass effect. Now that I, very briefly went over some epidemiology and pathophysiology of intracerebral hemorrhage, we can see that there is a huge concern and need for guidance with the management of these emergencies. So let's dive into some of the literature and guidelines. The literature surrounding time to management or time to reversal of anticoagulated associated ICH is very sparse. Kermatasu and colleagues conducted a large observational study that evaluated the rates of hematoma enlargement in patients with INR values that were reversed to less than 1.3. This study found a significant hematoma reduction and lower in-hospital mortality when a reversal agent was given within 240 minutes of arrival. Additionally, a more recent study by Perry Jones and colleagues implemented an ICH care bundle with the initial goal time of reversal of 90 minutes since presentation. Anticoagulation reversal within this time frame was associated with significantly lower 30-day mortality than patients who did not receive the ICH bundle. Overall, the need for emergent reversal is acknowledged to minimize hematoma enlargement. However, the optimal time window remains unclear. In addition to the sparse literature surrounding timing of reversal, anticoagulated associated ICH, the guidelines remain relatively vague on the specific timing as well. The 2022 guidelines for the management of patients with spontaneous intracerebral hemorrhage from the AHA-ASH guidelines recommend rapid reversal of anticoagulation as soon as possible after diagnosis, but don't specify timing. Additionally, and very similar to the AHA-ASA guidelines, the European Stroke Organization also recognized that time is critical for anticoagulation reversal, and similar to a door-to-needle time metric, a door-to-treatment time should be something that is considered. However, you can see that their recommendations are very vague, and just saying early reversal is recommended. So overall, you can see how literature and guideline recommendations recognize early time to reversal of anticoagulated associated ICH, but specific guidance around the timing remains limited. If we take a step back and even compare this idea of timing to treatment with acute ischemic strokes, we all know that that is well established, and that more rapid treatment improves outcomes among these patients with ischemic stroke. But evidence is less robust for patients with anticoagulation associated ICH, which carries a huge concern and need for investigation, which ultimately led to the process of the article Time to Anticoagulation Reversal and Outcomes After an Intracerebral Hemorrhage. The purpose of the study was to evaluate whether a door to treatment, or DTT time, is associated with outcomes among patients with an anticoagulated associated ICH treated with a reversal intervention. This cohort study utilized data from the American Heart Association Get With the Guidelines Stroke Registry. This registry is a large national registry that is a quality improvement registry for any cardiovascular disease in the US. More than half of the database involves stroke admissions, and this registry has been sourced as validated and reliable. Patients with a clinical diagnosis of a non-traumatic ICH were then stratified for this study. Overall, I think the utilization of this large national validated registry is a strength of the study, as it allows for a large patient population to be included. Those included in the study were adults treated with anticoagulation reversal within 24 hours of ICH symptom onset. Additionally, they had to be from a participating stroke registry institution and on warfarin or a NOAC prior to arrival. The prior to arrival was defined as use within the prior week. Some exclusions of the study included an in-hospital ICH onset, transfer from another hospital, or a diagnosis of a subarachnoid hemorrhage. Although these eligibility criteria are robust, I think there are some specifics worth recognizing. The study mentions and only captures non-traumatic ICH patients, which excludes what I think is a large population of patients that we would see pass through the emergency department. Additionally, although non-traumatic ICH was the inclusion criteria, there wasn't specifics surrounding the definition of what the authors utilized for this, which could differ from article to article, or how the authors perceived and included patients, and ultimately, could affect how the reader is interpreting who was included in the study. The primary variables involved in the study was a DTT time, or the time from hospital arrival to the start of a reversal agent administration. And as we will discuss further, the lead analysis was a comparison of a DTT time of 60 minutes or less versus more than 60 minutes. The selection of this 60-minute variable was chosen and extrapolated from quality targets for antifibrinolytics in ischemic stroke, as well as antifibrinolytics and imaging for ischemic strokes. Other variables that were included were specifics regarding anticoagulation that the patients were on, type of reversal agent, as well as time from onset to treatment and time from onset to arrival. The primary outcome was a composite inpatient mortality and discharge to hospice, while other functional outcomes of interest included discharge MRS scores, ambulatory status, discharge destination, and length of stay. Demographic and hospital characteristics were analyzed with descriptive statistics, And due to the large sample size, an absolute standardization difference greater than 10% was identified as being meaningful. Additionally, other variables were analyzed with a Cochrane-Mantel-Hansel test, which examines the association between two binary variables while also controlling for confounding nominal variables. If we're looking at the patient population that was included, the study found almost 38,000 patients screened with oral anticoagulation associated hemorrhage. Of those, roughly 20,500 were excluded, with the top reasons for exclusion being they were transferred or received reversal prior to arrival. They were taking other anticoagulants other than warfarin or a NOAC, or their INR prior to arrival was less than 1.4. After further exclusion, roughly 5,224 patients were included in the final analysis, as these patients had a documented reversal intervention as well as documented workflow time. If we dive into the baseline characteristics of the study population, we see a median age of 77 and less than half the population were female. This aligns with other historical studies of ICH and systematic reviews, as they find as age increases, so does the risk of hemorrhage, as well as men are slightly more at risk of developing ICH than women. Additional demographics from the study population include about 71% of the patients had a past medical history of AFib, 34% had a prior stroke or TIA, hypertension was seen in 84% of the overall population, heart failure was in about 20% of the population, and about 7% of the population smoked. I'm only highlighting a few of these characteristics. However, I do think the authors do a great job in gathering major risk factors that could put patients at higher risk for intracerebral hemorrhage. In addition to past medical history, the authors were able to gather some pertinent medications regarding the prior to admission medications. These include anticoagulations and antiplatelets. We can see that the majority of the population was on warfarin prior to arrival, while 22.5% and 15.3% took apixaban and rivaroxaban, respectively. Regarding prior to admission antiplatelet therapy, we see about 31% of the population was on aspirin. The last piece of key baseline characteristics worth mentioning include some of the neuro scoring tools. The IHSS, a validated scoring tool assessing the severity of stroke, was collected, and this population had a median NIHSS score of 12, representing a moderate stroke severity. If we look at the extremes, we see also a little over 20% had an NIHSS score of 0 to 4 or greater than 20 on admission. Additionally, the ICH score, a tool utilized to help gauge mortality, was reported to be a median of 2 in the overall population. This correlates to about a 22% risk of a 30-day mortality. I think the inclusion of the NIHSS and the ICH scores are meaningful to help stratify how sick and critical the patients were. However, I am surprised that a baseline MRS score was not included, as the discharge MRS score was assessed as a secondary outcome. It would have been nice to know a median baseline as well. The last piece of the demographics I wanted to include was that roughly 86% of the patients arrived by EMS. The median onset to arrival was nearly 2.5 hours, and the median onset to treatment was almost 4 hours at 232 minutes. Now, I know 4 hours does seem like a long time, which yes, it is, but you also have to remember this is onset to treatment, not door to treatment, which the article does provide, and I will show on the next slide. But it is something worth recognizing as far as onset to treatment, how maybe delayed patients are in seeking attention. This figure shows that distribution of DTT, or the door to treatment time. So we can see the majority of patients were treated within a range, roughly 45 to 90 minutes, with a median DTT of 82 minutes. So now that we have reviewed some of the key characteristics of the study population, let's walk through some of the outcomes and results. The primary result and major secondary endpoints were organized in Table 2 in the article. You can see that regarding the primary outcome, there was an 18% reduction of mortality or hospice discharge in those with a DTT time of less than or equal to 60 minutes. Additionally, with regards to some of the secondary outcomes, for example, the dichotomous analysis for MRS, there was no significant association between the door to treatment time and functional outcomes. However, as I had previously mentioned, a baseline MRS was not provided in the article or any supplemental data, as well as there was no major breakdown as far as length of stay. And I feel like these could really impact a patient's overall recovery and functional outcome status. In addition to the interpretation of the outcomes, the authors highlight some specific factors that were significant in regards to an association with treatment within 60 minutes. Some of those key factors included non-Hispanic white race, a lower NIHSS score at admission, as well as a treatment at a center with a greater annual number of reversals. I think this is a unique aspect that the authors included, as it really shows some of the diversity that we may see across the study, and it can really show how further commitment of resources in terms of care, education, and access is very important for everyone across the nation, so we're getting the same level of care. Overall, I think this study had many strengths and limitations worth recognizing. The utilization of a validated and reliable registry was definitely a strength of the study, as it attempted to capture all the ICH incidences across the nation. I felt that the primary exposure variables of time from onset, as well as time to arrival and start of the reversal, as well as the specifics surrounding the anticoagulation utilized, were strengths of the study. I think although a baseline MRS was not included, the utilization of other validated and commonly utilized severity and neurological measuring tools like the NIHSS and the ICH tools were also strengths of this study. I do think that the registry did a great job in being able to extrapolate some specifics regarding the hospitals, which also led then to that table that I displayed as far as factors that could affect the door to treatment time and definitely can impact our future implications and things to consider. Although there was a lot of strengths of the study, I do think there are some limitations worth recognizing. One, I know I speak highly of the utilization of the registry as a strength. However, I do think it could possibly be a blessing and a curse, as the data was highly dependent on the accuracy and completeness. Additionally, like I had mentioned, the population excluded trauma anticoagulated associated ICH patients, which I do think is a limitation, as I've seen as a huge portion of the population that present to the hospital. Also, with an observational study, there's always a risk for confounders, and although the study did attempt to adjust for those, which I do applaud them for, there's always a chance for missing data regarding reversal agent intervention status, as well as timing of administration, which can also induce some selection bias. Last, the supplemental data does provide some information regarding the breakdown of which reversal agents were utilized, but there is no specifics regarding dosage, and a majority of the patients had missing data for this. In a similar way, we know that effective supportive care and supplemental therapies is very critical in the ICH patient population and can help reduce mortality. The study does not mention or go into the supportive care that was utilized, and likely it was not standardized across the hospitals. Again, this possibly could impact the overall primary outcome as well as affect the validity of the study. So a big picture conclusion from the author is that patients who received a reversal for anticoagulated associated ICH with an appropriate documented data saw a decrease in in-hospital mortality or discharge to hospice. Although this result is meaningful, there are some other points that we should not overlook. The study did reveal that less than 1 in 3 patients with an ICH on anticoagulation were reversed within 60 minutes. and patients with a mild stroke severity, which you could classify as an NIHSS score of less than 5, were also less likely to receive a reversal intervention early, even though these patients have the risk for neurological deterioration and could be beneficial to have received reversal. These conclusions from the author, as well as the results, support my overall summary and conclusion. Like I had mentioned, it is established that more rapid treatment improves outcomes among patients, even when we think about acute ischemic strokes. But like we have seen, evidence is less robust for patients with an anticoagulation associated ICH. This large trial serves as the first description showing that early administration of a reversal treatment in anticoagulation associated ICH is correlated with a reduction in in-hospital mortality or discharge to hospice. I do think additional studies, data, and literature should be done to focus on the impact of reversal treatment and the association to time. I do think that this trial and any further studies can be used to help justify the need for potential quality improvement programs and education initiatives, as it could work to identify and mitigate any barriers to earlier door to treatment time in ICH. Because just like in ischemic strokes, time is still brain for these patients as well. And with that, I am open to any questions.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.